Hello everyone, my name is Tanvi Karmarkar and I'm a fourth year medical student at UMKC. I wanted to talk a little bit more about my project titled Improving Food Insecurity Documentation in University Health Patients' Charts. Food insecurity is currently on the rise and COVID-19 has not helped ease this burden. So we wanted to see what are we doing at University Health to help document food insecurity and address this concern that a lot of our patient populations probably have given the high rates of food insecurity in the Kansas City area. So currently at University Health, nurses are responsible for completing a social determinants of health screening tool. However, physicians are rarely aware of the screening tool. Now, the tool includes questions about access to transportation, medications, and food. This study specifically focused on the question regarding food insecurity that asked patients if they have ever had to skip a meal because of inadequate food. However, because physicians are not aware of whether or not their patients are food insecure, it leads to gross discrepancies, both in terms of treatment as well as in terms of disease burden when it comes to paying for the treatments that patients have received. And so this project is an attempt to improve the accuracy and thoroughness of patient medical records, as well as increasing physician awareness of food insecurity amongst their patient population. Now, this was done specifically by using medical students to extract information from the social determinants of health reports and add the appropriate ICD-10 codes to the problem lists that physicians are aware of. And so when looking at methods specifically, about 33,000 surveys were completed between January 1st of 2020 and January 1st of 2021. Now, the responses to these surveys were tabulated and then divided based on the response to the survey. Then for patients who said yes, they were food insecure, their specific chart was opened and the problem list was reviewed. And if the problem list included the specific ICD-10 code, which is Z49.5, which states that the patient is insecure, then no more action was taken. However, if this code was not present, then further action was taken, which included adding the appropriate code to the patient list. And it was found that about 85.3% of patient problem lists did not have the appropriate code when the patient had said in the social determinants of health survey that they were in fact food insecure. So when looking at results, it is clear that a lot of patients were saying that they were food insecure, about 3%. And when looking at the second graph, we can see that food insecurity rates were evaluated throughout the US, which showed that for the majority, urban areas had more patients that were likely to say they were food insecure as compared to rural areas. However, there was a discrepancy in the Midwest, which could be attributed to the fact that more patients in the rural areas were administered this survey as compared to the urban areas, leading to this discrepancy. And in conclusion, it is clear that many findings from this study showed discrepancies both in terms of physician awareness regarding food insecurity, but as well as data incompletion, that is, lack of data. Because when comparing food insecurity rates for the Jackson County area, which was about 15.3% over the period during which the study was administered, only about 3% of the patient population said that they were food insecure, and this is a large difference that should be addressed. And along with the findings that are outlined here, another important result of the study was that an automated process was implemented at Lakewood Medical Center, where any positive findings in the social determinants of health survey automatically triggered the appropriate ICD-10 code into the patient problem list. And so it would be interesting to see the impact of this, both in terms of physician awareness as well as patient responsiveness. That is all. Thank you.